Hello everyone, my name is Nadia Rose and I'm the CEO of Head and Neck Cancer Australia. Welcome everybody and thank you for joining us for our second webinar this year, which is kindly supported by the Western and Central Melbourne Integrated Cancer Service. I'd like to start today by acknowledging the Aboriginal and Torres Strait Islander peoples of this nation. I acknowledge the traditional custodians and sovereign people of the land across which we meet and pay my respects to elders past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islander people joining us today. I am joining from Gadigal land of the Eora Nation. We couldn't the important expertise of our guest speakers, and today we're very lucky to have Dr. Lachlan McDowell from Peter MacCallum Cancer Centre in Victoria and Associate Professor Haryana Dhillon from the University of Sydney speaking with us. We're also incredibly grateful to have Denise Whelan, a former patient and one of Head and Neck Cancer Australia's ambassadors from New South Wales with us, and Ron Rongetti, also a former patient from Victoria, who will join us for a panel discussion to share with us their personal experience on what fear of cancer recurrence means for them. We'll hear more about our guests a little later on. I'm delighted to hand over the hosting of today's webinar to Kellyanne Jolly. Kelly has over 30 years experience as a leader in public health and health promotion, most recently as the CEO of the National Heart Foundation of Victoria and Tasmania. Kelly has her own lived experience of uterine cancer and is passionate about prevention and early detection. Kelly is a strong advocate for community engagement and the need for organisations and services to actively listen and respond to the voices of consumers to ensure quality care. Thanks, Kelly, for being with us today, and over to you.
Thanks so much, Nadia. Well, I am delighted to be here to be emceeing your session today. And as it's a really important topic, one that I think concerns and affects so many cancer patients, and particularly those that have had head and neck cancers. I know myself from someone who has a lived experience of cancer. This is something that has affected me to varying degrees over my journey. We have, as Nadia said, a great program for you today. Two speakers, Lachlan and Haryana, and really terrific to have two of our former patients with us today that I'll be taking through a bit of a conversation discussion about their own insights and experiences. I think just from the fact that we have such an amazing registrations to this webinar just demonstrates the importance of the issue, and it's something that we really want to learn more about. But first, I too would like to acknowledge that I'm on the land of the Wurundjeri people, which is in Melbourne, and would like to acknowledge and pay my respects to elders past, present and emerging. I just want to remind those before we get started who haven't participated in one of our webinars before that it is interactive. We want you to ask questions using the chat function at the bottom of the screen at the end or during the presenters when they're presenting. But also to thank those who have pre-submitted some questions. We've had a lot of questions already that have been pre-submitted in your registration, so we will hope to get through as many as we possibly can during the time that we have available. But I just wanted to remind everyone that we are unable to address more individual cases, questions that are specific to your particular personal issue. So if you do have a personal question, we encourage you to contact your cancer care team, or alternatively even Cancer Council Australia on 131120, and they should be able to help you a little bit more. We understand that some people may not have been able, for whatever reason, to make it today, and even those who are online today might like to hear our speakers again in your own time. And so the webinar is being recorded and will be shared on social media and also on the HANCA website over the next few days. So please check that out if you want to look at it again. But before we start, we are going to just have a few poll questions. Now, some of you who might have been involved in a webinar before might have been through this process. really the participation is voluntary, it's anonymous, and it's really giving us a bit of a collective idea of what the experience of the participants are, and the perspectives both from a patient or former patient and also from healthcare professionals. So you'll get a few seconds to answer the questions. They're actually aligned to the audience. So there are 3 questions that are going to come up first, which are really relating to if you're a patient or a former patient. And then there's 2 questions that are more specifically focused for healthcare professionals. So once we have gone through and got a bit of an idea, you don't need to dwell on them. They're coming up now. So if you can just make your way through, and then we'll have a look at the results once we've gone through. So you should see some questions coming up now, and this is for patients and former patients. Have you experienced fear of recurrence? Who did you speak to? And there's a number of options there. And what helps you the most to cope? So perhaps if you just answer those, if you're a patient or a former patient. I'll give you a few more seconds to answer those. And then number 4, are you asked about fear of recurrence by your patients? If you're a health professional, do you feel equipped to support your patients if you're a healthcare professional? Quick multiple choice. First thing that comes into your head, just to give us a little bit of an idea of what's happening. Okay, I think we might have a look at the results now. I think that's probably enough time for people to have popped in their answers. Do we have any response yet? Here we go. Right, if we have a look, have you experienced fear of recurrence? If you look at our patients and former patients, we have 54% are saying yes, and about 46% saying no. Who do you speak to? We're seeing most people are looking at the cancer team and friends and family at 23%. Then we're looking at GPs at 8% and a counsellor at 4%. Interesting to see that friends and family are featuring there. Then we go down to no one, which is an interesting point here. That's something that might pick up, is 65%. What helps you most to cope? Exercise seems to be high, 35%. We've got meditation at 19%, counselling at 8%, hobbies, which is another a good one, 23%. And we've got quite a few where obviously there's a lot of individual things that people are doing under other. Are you, now when we look at the healthcare professional group, are you asked about fear of recurrence by your patients? We're getting about 38% saying yes, 38% saying yes, and 62% saying no. So that could be an issue that we might want to look at later as we go along. Do you feel equipped to support your patients? Somewhat, and it's great to see so many healthcare professionals on the webinar today, and that might be why, because they feel they would like to be better equipped. Yes, 20%, 7%, and no, 27%. So thank you very much for giving us some insights into your experiences of fear of recurrence and some of the things that you're interested in. So thank you for doing that. And now we might move on to our speakers. We are really privileged to have Dr. Lachlan McDowell with us today. Dr. Lachlan McDowell. Lachlan is a consultant radiation oncologist at the Peter MacCallum Cancer Centre here in Melbourne, where he's been since 2016, and he's been specialising in the treatment of head and neck cancers. He graduated from the University of Queensland back in 2008, so a little while ago now, and he received his fellowship in radiation oncology from the Royal Australian and New Zealand College of Radiologists in 2015. And in that same year, he also did a clinical and research fellowship, or undertook it, in head and neck radiation oncology. And he did that at the Princess Margaret Hospital in Toronto in Canada. Lachlan's main research interests include clinical outcomes, health-related quality of life, really important, and unmet needs in head and neck cancers. And if that's not enough, he's also enrolled in a Doctor of Philosophy at the University of Melbourne. And he's particularly focusing on gaining a better understanding of the long-term quality of life and unmet needs of survivors with human papillomavirus-associated oropharyngeal cancer. And he has a specific interest in sexual health outcomes and a fear of cancer recurrence. So very capable of talking about this issue today. So welcome, Lachlan, and we look forward to your presentation.
Thanks very much, Kelly, for that introduction. And I'm really excited to have the opportunity to speak with, the audience today. And I guess impart some of my experience I've had as a clinician who's interested in fear of cancer recurrence. And I guess, with the overall goal, I guess, of normalizing this as a normal experience that almost all patients will experience through their cancer journey. Up to 50 to 80% of patients will experience fear of cancer recurrence at some time during their survivorship journey, from any point from diagnosis through to survivorship. So this is really a very normal experience that many patients will have as they go through that pathway from diagnosis through to survivorship, and to that 5-year handshake that we all hoped to give our patients. What I really want to cover today, I guess, are 3 main aspects around fear of cancer recurrence. We'll define it, I guess, normalize the experience of patients around what the literature tells us about what other patients experience. And I will go into some research, but this will really just be to, I guess, illustrate, I guess, the common, how common it is in patients with head and neck cancer, and I guess to impart some understanding of what we see in terms of trajectories, in terms of whether it gets better with time or not. And I'll finish up with, I guess, some of my clinical experiences and observations. I'm obviously not an expert in having experienced fear of cancer recurrence, but this will be, I guess, what I see happening in my patients in clinic. Fear of cancer recurrence is the fear, worry, or concern that someone's cancer will return or progress. And this can be either at the site where it started or at more distant sites. We know that this is a very common experience for many patients. When we look at all cancer survivors, so not just specifically head and neck cancer patients, this fear of cancer recurrence really emerges as one of patients' greatest concerns when we ask them what are they most worried about. When we look at all cancer survivors, we'll see that almost up to 90% of patients may report moderate to high rates of fear of cancer recurrence. And then a smaller proportion, somewhere up to 15 or 20% of patients may report very high rates of fear of cancer recurrence. And this is really important for us to understand. We know that those patients who report higher rates of fear of cancer recurrence will also report worse quality of life. We also can see that it interferes with people's social functioning and their interaction with family and friends. And it's also been associated with increased healthcare utilisation. When we focus specifically on those patients with head and neck who have experienced head and neck cancer, we know that head and neck cancer is a unique population of people with the side effects, and treatment is unrelenting. And head and neck cancer patients, unlike other types of patients, may experience different types of distress to other cancer survivors. And these are things that are somewhat unique to head and neck cancer, such as mask anxiety, concerns or distress around changes in appearance. And these types of distress may also be associated with patients going on to subsequently have higher risks of fear of cancer recurrence, or experiencing a high severity of fear of cancer recurrence. Again, this is not unique. You know, head and neck cancer patients, like many other cancer, different other types of cancer, will rate fear of cancer recurrence in their top few concerns. And we see very similar numbers when we look at the severity in patients with head and neck cancer. Again, those numbers of 30 to 80% of patients experience high FCR is similar to what we saw in the general cancer population. We also see some other consistent findings in the literature. The degree to which patients worry about their cancer coming back is very infrequently associated with the actual risk of it coming back. And I guess what I mean by that is that patients who have a low risk of cancer coming back, that doesn't mean that they're unlikely to experience high rates of concern around whether their cancer will return. But we do see some fairly consistent findings in the literature in terms of those patients who may be more at risk of developing higher FCR. And those are fairly typically, we see younger patients reporting high FCR. In some series, we see female patients reporting higher FCR. And then we see other factors, baseline psychological and personality factors, and established coping mechanisms that they may impact how people, whether they go on to develop higher rates of FCR. Also, I would challenge that for, certainly from a clinician perspective, I think there are many people who just feel that FCR reduces with time. Certainly that may be the case for some patients, but it's certainly not what we see in all patients. Scan-related anxiety is a very similar concept. Patients may experience a high level of distress around the time or after the time that they have a restaging scan. And it typically peaks in between the time the patients, or at the time they're having the scan, to the time that they're getting results. I would also suggest, at least from my clinical experience, that patients getting appointment reminders can prompt very similar responses in patients. And this is very common. Again, very similar numbers, up to 85% of patients or more may report a high level of stress or concern around the time that they're having their staging scans. And there can be many different types of trajectories. This can build up for patients before treatment, or last through to the time that they get their results. And I think this is a really key issue to discuss with your oncologist. There are a number of questions that came through today from patients, and I'm hoping that this may address at least some of those questions. There's not a high level of evidence in terms of how frequently we scan patients after treatment. There's no general consensus among all of the oncologists and surgeons on how closely we need to monitor these patients. And this can be a really individualized discussion with patients, and it depends on how accessible the tumor was to clinical examination, and I guess the various risks in terms of where patients, where they harbor that risk of recurrence, whether it's at the primary site or whether it might be in the neck or other sites, for instance. For instance, I think for many patients with HPV oropharyngeal cancer, what we typically do at Peter Mac is a PET scan 3 months after treatment. About a third of patients will need a second scan just to allow things to settle down. And really beyond that point, there's no evidence that doing further routine imaging in patients who have no symptoms actually adds any benefit to patients, but especially those patients who don't have any symptoms. And that's been our policy. And certainly, but what I have seen is that people will develop a high level of anxiety around the scans, which are not providing any useful necessarily useful information to them or to their management. And also, but it can actually create a situation where people are having unnecessary tests for things that might come up on a PET scan that resolve with time that we never needed to know. So I think this is really an individualized discussion that I would empower patients to have a discussion with their clinicians about. I'll talk briefly just about when the researchers and clinicians are saying FCR, sometimes we might mean that we've asked patients to tick a box on a list of concerns that they may have. I mean, that's a very valid way of assessing the, I guess, frequency or how often patients are worried about fear of cancer recurrence. We also may measure severity or any other number of aspects, particularly how FCR impacts patients on a day-to-day basis, the degree of distress it causes, and how much functional impairment they will get when those feelings arise. This is a busy slide, but just to illustrate that this is a very common, when we ask patients or poll patients after treatment, how frequently do they tick the FCR box? And it's very frequent. So it's often frequently ranked in the first or second concern that patients will have after they finish treatment. I think this is an interesting slide for a couple of reasons. What we see is that patients worry about fear of cancer recurrence often from the time of their diagnosis. More than 50% of patients will report, when we ask them about fear of cancer recurrence, will report in the high range from the time of their diagnosis. When we look at how patients, the trajectory that they follow after completion of treatment, I think this illustrates, I guess, what fits with the clinical picture is that, yes, there are patients who will decline slowly after treatment. Those patients are the patients who tend to have lower fear of cancer recurrence at the time of diagnosis. But for those patients who score highly when we're measuring fear of cancer recurrence at the start, those patients will often have a trajectory that remains relatively stable after completion of treatment, at least for the first 6 months after treatment. And this is important because it suggests that we should be trying to identify these patients early on during the course of their cancer diagnosis and treatment. And again, what we've seen, that trajectory is associated with patients who are younger, and some personality and psychological traits around how patients cope, adjustment, and I guess some patients who have avoidance strategies around clinic appointments. This is just to highlight some of the work that we previously did at Peter Mac. We focused in on patients with HPV oropharyngeal cancer. These were patients who were more than 1 year following completion of treatment. These patients were treated with definitive chemoradiotherapy, so surgery was not part of their treatment package. So these are patients who are more than 1 year following treatment, and still those patients are reporting very similar rates of fear of cancer recurrence to the other studies that I showed at the start. Approximately 50% of patients reporting moderate to high rates of FCR, and about 20% of patients reported scores in the high range. We saw a number of factors that were associated with reporting high FCR scores or experiencing higher FCR, and those were patients who were younger, who had lower medical comorbidities. And as I said at the start, we also saw that those patients had markedly worse health-related quality of life and higher rates of anxiety and depression. I think there's still a lot more work that we need to do. We're measuring this in a current study. Hopefully we should be reporting some of this next year, looking at other factors that may help predict whether patients are going to exhibit or experience higher rates of FCR in the long term. And these are things such as resilience and optimism. We're also asking patients where they want support for. I'll go to a little bit about that as to what my experience has been in trying to get patients to referred on for assistance with FCR. One thing I would highlight is that I think that doctors are not necessarily able to pick this up without specifically asking patients about it. And there may be a number of reasons for that, including that it also doesn't seem to be something that patients will always routinely disclose to their oncologist without being specifically prompted. That's been my experience. Other patients and other doctors may have different experiences. But there is some data to suggest that head and neck cancer patients may not want to appear ungrateful or mention FCR for fear of worrying the relationship that they have with their head and neck cancer doctor. One of the other factors I think is important is that head and neck cancer clinics are busy, they're overloaded, and unfortunately, and something that we need to work on as a specialty is really, I think, emotional distress measures of survivorship for head and neck cancer patients are frequently overlooked. And that's because historically we've focused heavily on surveilling patients for recurrence and also focused heavily on the physical aspects of treatment. And I think we need to do better at screening for this, particularly FCR, but also other aspects of emotional distress. I would also argue, or not argue, but mention that I think sometimes as a specialty, we may not use language that confers exactly what we're meaning to patients. One day I told a patient they had a low risk of their cancer coming back. And as I was walking out of the room with the patient, I reflected on whether what I thought a low risk of recurrence was the same as how the patient had interpreted. And from my perspective, my interpretation of low is less than 10%. But when I asked the patient as they were walking out, their interpretation of that was about 40%. And I think that kind of highlights just an important aspect of how we deliver some of that information to patients, because we obviously had to sit back down and have a discussion about that, because I certainly didn't want a patient walking out of the room thinking that their risk of recurrence was 40% when they were almost very unlikely to have a recurrence in the future. I think it's okay. It's definitely okay for patients to discuss beyond the physical aspects of treatment with their oncologist. And I think that if you are experiencing a high degree of worry about your cancer coming back, this is something that your oncologist wants to hear about. The FCR experiences, I think, vary a lot from patient to patient. We see patients who I see who the one appointment they have every 6 months, that clinical reassurance is sufficient for them until their next appointment. For some patients, it may be purely situational. When they're in the waiting room, it may bring back those feelings, I guess, that they had when they were being treated for cancer, and that doesn't really bother them when they're outside of the room. But for other patients, this may be a pervasive issue on a day-to-day basis for them. And that's not the only trajectories. Every patient's an individual, and patients, including people on this forum, may have other experiences. Do patients want help with fear of cancer recurrence? I think this is, I'm not meaning to be overly provocative with this statement, but what I have found it challenging is to get patients to agree to a psychology referral, to give them the strategies that they need to help with fear of cancer recurrence. And I would highlight that probably the oncologist in many circumstances may not necessarily be the most skilled professional who can assist patients in managing their fear of cancer recurrence, particularly when more, when more detailed and more coping strategies and those kind of strategies are needed to be implemented to help contain those feelings of FCR. So in summary, what I'd really like to highlight is this is a really normal experience for most cancer patients, including head and neck cancer patients. We see almost up to 80% of patients in some studies reporting significant FCR. There are certainly cohorts of patients who appear more vulnerable, and those are patients who are younger or may present with baseline anxiety. And I think as a specialty, we really need to improve measures, particularly around how we screen for psychosocial distress, including FCR. And I don't think that relying on clinician intuition to pick this up is an adequate way. And I would really empower patients to discuss this with their managing clinicians and cancer treatment team. Thank you.
you, Lachlan. I think I'm on. Yes, there I am. Thank you. That was really interesting, and you covered a lot in your presentation. I think I was really interested in when you were talking about language, which is something often that isn't picked up, and that notion of what interpretation, expectation of low risk. I thought that was really interesting, and something often we don't think about, and the different interpretation. We could have a really big impact on a patient walking out if they have a different view. And also, I think what you were talking about relating to patients feeling a little bit more reluctant potentially to have the psychosocial or some kind of referral. I'm wondering if that is in some way related to some form of stigma around what does that mean and what are you thinking if the fact is that you need a referral. So I don't know if you want to make a comment there, but we do have a few other questions coming through. But yeah, that's, and the other thing I think that was of interest to me too is the whole area of if we can try and identify this early. And be able to have that conversation, both the health professional reaching out to the patient, but also the patient being able to feel empowered to be able to raise this with their professional. So I don't know if you've got any comments around that, but otherwise we'll go to the questions.
Yeah, I just quickly, I mean, I really, you know, I ask a lot of patients about their fear of cancer recurrence, and it really, and the way I phrase it, I hope I'm trying to get patients around some of the stigma, but you know, I have personally found it very challenging, even in patients who I can see it's actually, you know, it's actually really impacting them. Hopefully Harry will have some, you know, maybe some further advice, on that one. But the language one I think is very important, and I think if doctors are using language or your cancer team's using words like low, medium, high, and patients feel that they need more clarity on what that actually means, I would really encourage people to ask their doctor, well, what do you mean when you say it's a low risk of coming back? They still might not be able to provide exact, you know, like to the decimal point, and it's probably more likely going to be a range, but at least that range I think is more workable than words like low, medium, high.
Yep. Great, thank you, Lachlan. Just anyone got any questions, please add to the chat. And I think, Lachlan, we could be able to pick up a little bit more in our panel actually with Denise and Ron about some of their experiences with this too, from having had that lived experience. All right, well, we might just move over to some questions. We have got a few that have come through before today, and then there'll be some more coming through on the chat. Firstly, I think you kind of answered there's two here, one from Fiona from WA and the other one from Ross at New South Wales. Fiona asked about how often should monitoring scans be done and what kind, and I think you did pick that up. And the other one from Ross in New South Wales was he was feeling relieved after 3 years that his follow-up appointments are moving to 6 monthly. But the prospect, and I think this would be probably, a lot of people would feel like this, the prospect of moving to yearly appointments was a little bit concerning. And so he was asking, should 6 monthly follow-ups be maintained for 5 years? So those two are really around follow-ups and monitoring. I don't know if you want to answer those first.
Again, I guess these are really individualized situations, and everyone's individual risk, I think, is, you know, these are things that are worth discussing with your doctor. And also, I guess it also highlights, I guess, the language, because when we're saying to patients, well, now it's okay to go to, you know, to 12 monthly, what that we're actually saying is that your risk of recurrence has dropped substantially, enough that we don't need to see you as frequently as what we currently have been at 6 monthly. There's, you know, whether it's 6 monthly, three monthly, there's not really good established guidelines in terms of, or consensus, as I mentioned, on how frequently patients should be seen. I think when patients are asymptomatic, that's a very hard group to know exactly how much. You know, I can't really recall that many times when we're seeing patients in that, you know, who've had a clear PET where I've ever really picked up a local recurrence in the in the clinic, or even on, really even on imaging. But that, again, that will vary, and I think you need to discuss that with your doctor. But it should be reassuring that when we're starting to stretch out your appointments, that should be rather than causing anxiety, should actually be really reassuring to patients. And for most head and neck cancer, what we see is the biggest risk of recurrence is in the first 2 years. It tails off in the third year, and then it's really quite low after that. And that's why those appointments are stretched out. And really, I guess having that, having a good connection with your oncologist to be able to reach out if something changes, that's probably the more important, I guess, trigger for scans.
Yeah, thanks, Lachlan, rather than going with a specific time. We've got lots of different questions coming in, so I'm just looking at which ones we can grab. There's one here from Sue online who said, do you have any data for patients who've had more than one episode of head and neck cancer?
Sorry, can you just repeat the question? Sorry,
do you have any data for patients who've had more than one episode of head and neck cancer? So the level of recurrence, do you have that?
No, I don't know that that's a group that we've actually, that we actually have any data on, I guess, on measuring severity. And I guess that would be very anecdotal, person-to-person experience that we might be able to learn, certainly a group of patients would be able to learn more from.
Yeah, okay, thanks. We've got Chris has asked, fear of recurrence is proportional to the evidence on risk of, hang on, I think that's an answer. No, fear of recurrence is proportional to the evidence on risk of return. Can you give more information about this, not just for 5-year handshake, but also afterwards? I think we've just kind of covered that. I think it's really, do you get that question? Would you like to add anything?
My interpretation from that question is, I think people are not immune based on their stage as to whether they're going to experience these, high, a high severity of fear of cancer recurrence. And, you see this in the clinic. You see patients who have very advanced disease, who this doesn't seem to be an issue for them. And then you see patients who have early stage disease, who it is a big worry for. So I think it's not, when you look across many of the series, and it's not even just head and neck cancer, patients' risk of being affected by fear of cancer recurrence is generally independent of the risk of that, of the risk of it coming back.
Yeah.
And I think the second half of that question, I'm not entirely sure what happens to patients' fear of cancer recurrence after the 5-year mark when they're being discharged, for clinic. For some patients, it seems to be a relief and they don't want to have to come back again. But I do wonder if there's a cohort of patients who maybe that they're still even though their risk is very, is close to non-existent, that they're still harboring quite a high level of fear. I guess we don't know that.
Yeah. Okay. Thanks, Lachlan. I think that was a tricky one to answer. We've got lots here, and I've realised that we're running out of time, so I might just look at one more here that we might have. Although this one might be better for Harry, actually. I've asked my surgeon and radiotherapy oncologist about expectations regarding body image and pain. I was consequently labelled a warrior with high anxiety. Is there a way I can ask the question without? It hasn't fit, that's the end of the question. So I think it's space. Is there another way that without getting that kind of response? I think was probably what this person, and it's anonymous.
Well, I don't think patients should be anxious about being anxious. They shouldn't be anxious about having to ask questions about their anxiety. I think patients should, my preference would be to hear it in a very, I don't really know how to answer that question, because I think it's probably dependent on the person who's receiving the information. But I think people should just be genuine and raw about what their experience is. And that's the way that, you can understand what patients are going through. That would be and if you're worried about it, then you should just convey that which is appropriate to your personality. And I think when you start moving away from it being genuine because you're trying to worry about what the doctors actually think, I just don't think it will come across as the way it needs to.
Yeah. Thanks, Lachlan. Nadia, I don't know, there's so many questions here. I'm not sure if we want to keep going, but we might be able to pick them up a little bit later if we have time, I think, because there's a lot coming through, and I don't think we need to. Yeah.
Yeah, I'm more than happy. Let's give Harry a turn. Thanks, Lachlan.
Yeah, thanks so much, Lachlan. There's people thick and fast coming through, so we might be able to pick them up later, but we'll move on to Harry, or Associate Professor Haryana Dillon, is a Senior Research Fellow who co-leads the Survivorship Research Group and is a Director of the Centre for Medical Psychology and Evidence-Based Decision-Making at the School of Psychology at the University of Sydney. They always make these such long-winded names, don't they? Haryana has more than 25 years' experience in cancer clinical research across a range of investigator-initiated cancer clinical trials. And her research interests are broad, including cancer survivorship, health literacy, and interventions for survivorship, symptom management, and psycho-oncology. Haryana is passionate about rigour in research, but she's also interested in the practical solutions to tricky problems. We always need those people, and doing what she can to help humans, to help people make it into the 22nd century. So welcome, Haryana, and over to you.
Lovely. Thank you so much, Kelly. And thanks, Lachlan, for doing such a fantastic job of setting the scene. And so my job really here today is to talk a little bit more about the practical aspects of fear of cancer recurrence and the things that we can do that might help. And as I get started, I'd also like to acknowledge the traditional custodians of the lands on which we all meet today, and do acknowledge also the disproportionate impact that head and neck cancer and many other illnesses have on First Nations people of Australia. So I will touch a little bit on some slightly different aspects of what is fear of cancer recurrence and some of the therapeutic approaches and interventions that we have, and some of the new initiatives, because a lot of this work is still emerging as we speak. So I just wanted to kind of say, particularly not to repeat what Lachlan has already said, but really just to highlight the fact that some level of fear of cancer recurrence is not irrational. And in some respects, it can be quite helpful in prompting us to maintain those health behaviours and activities that help to monitor for potential recurrences and be aware of those. But what we don't want is for those things to become intrusive in our lives. And so we don't want people to be focused so much on the potential that the cancer might be coming back that they stop doing everything else and they can't enjoy the rest of their lives, which is really the whole priority for all of us. We know that the features of clinical fear of recurrence can be things like worrying about the recurrence or being fearful of it, being preoccupied with symptoms and other body sensations. And some of the other aspects may be unhelpful coping, things like avoiding follow-ups or excessive distress and having difficulties planning for the future. So they might be some of the things that you'll be experiencing if you have a clinical level of fear of cancer recurrence. And we kind of know that there are these particular areas that we think are very important. So coping, functional impairments and excessive distress, and how we might go about addressing those can be measured in different ways. So what I wanted to really highlight was one of the first really high quality interventions that was developed here in Australia and trialled here that may also be quite helpful in thinking about this. So as as psychologists or behavioural scientists, the people that work in psychology, we're very much focused on what it is about people's thinking and behaviour that can be changed. And so we take a very theoretical approach. And when we looked at this as starting to develop our Conquer Fear intervention, there were a number of different models, and they're not particularly important for you to understand, but they had when we reviewed them, there were some things that were quite common across these different models that we could target in terms of psychological tools that would help people to perhaps cope in different ways and perhaps better with these fears of recurrence. Oops. So the theoretical perspectives that we really looked at were, one of them was called the common sense model, which I really like because it's nice and simple. And there are some things that help to identify how this might be helpful to people. So some of those internal cues that people experience, so the feelings that you experience that stimulate you to think about the fear of recurrence and the symptoms that people have. The external cues might be those contacts with healthcare professionals, the way that head and neck cancer or cancer in general is reflected in the media, and it's almost constant, and as well as those other things that Lachlan also mentioned in terms of follow-up scans, PET scans and CT scans and things like that around their potential to promote or highlight this experience of fear that people may have. You may have some thoughts or cognitions around your perceived risk of cancer and the potential outcomes of cancer, as well as worry emotions, which might include worry and anxiety or regrets about treatment. And then the consequences of that might be things like behaviours that mean that you're more aware and you're checking your body more regularly, seeking reassurance, or perhaps alternatively avoiding planning for the future. And it can lead to sometimes feelings about anxiety and panic and misinterpretation of symptoms. So some of these things are ideas and concepts that we can target psychological interventions to, or these tools that I mentioned earlier, that can be really helpful to people. So we can challenge some of those, the content of the thoughts. So, thinking about cancer is not all about how catastrophic it is, and also to challenge some of those ideas about unrealistic risk perception. And I think the point that Lachlan was making about understanding when we're communicating as health professionals with people who have the lived experience is really important as to what each of you is interpreting particular words to mean. We can provide education about what's recommended and and encourage adherence to that, and also encourage people to express their emotions about what it is that they're afraid of and fearful of, as well as teaching relaxation strategies to help maintain that. The relational frame theory, which is really based around acceptance and commitment, focuses on the idea that people avoid negativity, but it maintains a cycle of negativity and blocks realization or achievement of people's values and goals. So what it's aiming to do here is to teach people acceptance of particular sensations and non-engagement with thoughts and sensations when they occur, because attempting to control them can be counterproductive, and that can prevent individuals from acting in line with their values and their goals for the rest of their life. So some of the kinds of tools that we use in acceptance and commitment theory are particular mindfulness approaches, so not engaging with rather than trying to avoid or worry about particular thoughts, other forms of meditation, body awareness and yoga, being very clear about what your values and goals are so that you're living in line with what you think is really what is important to you, and committing to act on those. And self-regulation theory of executive function really focuses much more on thinking. So it's the idea that accepting that negative thoughts and emotions are normal and they're transitory. And those emotional problems can be caused by self-regulatory thoughts and emotions. So it's sometimes unhelpful metacognitive beliefs, by which I really just mean the unhelpful beliefs about thinking and emotions, or unhelpful information processing style. So it may be that some people will believe that worrying about being worried is helpful to them in some way. So what we want to try and to do is to address some of those things and and try and reduce the impact and the likelihood that people are going to be experiencing anxiety as a consequence of that. So we challenge the worry. It's useful, but maybe some of the things that you might do, which sound really simple, is to set aside, if you are someone that worries a lot, that setting aside a time to actually worry about everything, and then agreeing, committing to not doing that at any other time in the day. Another technique is attention, called attention training techniques, and it's really helping you to train your attention in particular directions. So attention can sometimes be thought of a bit like a muscle, and if you exercise it regularly, then it can be quite a useful way of dealing with thoughts that come into your head as well, by turning your attention to something else. Or detached mindfulness, which is a particular way of observing thoughts and worries without reacting to them. So we took all of these things and developed an intervention called Conquer Fear, and there were many people involved in that process. And we then did we developed a psychological manual for this, and it's delivered as individual face-to-face therapy with a clinical psychologist or registered psychologist. It goes for 5 sessions, and the aim, as I mentioned earlier, is not to get rid of worry, but to assign less importance and attention to the worries about fear of cancer, the worries about the cancer coming back, and also to help develop goals to give your life meaning, purpose, and direction. And if the 5 sessions cover values clarification, so living according to your values, attention training, so gaining control over your attention, detached mindfulness, the non-engagement with worry, and metacognitive therapy is in terms of learning to not to worry about worry, or that worry is not a positive thing, and then some behavioural contracts for making sure that you're engaging in an evidence-based and healthy way with follow-up and with other aspects of your healthcare. So we did a randomised control trial in 220 odd people, half of whom got Conquer Fear intervention, and the other half had a relaxation intervention. So it was an active control. And what you can see here is that we did demonstrate a very marked reduction in the fear of cancer recurrence in people who got Conquer Fear, and that was sustained out to 6 months after the intervention. We also saw a decrease in the severity of fear of cancer recurrence in the certainly first few months after the intervention. And we also saw a reduction in general anxiety. So general anxiety is not the same as fear of cancer recurrence, but they sometimes can be quite closely related. And we were really pleased to see that Conquer Fear also meant that people were less anxious overall, and also had better mental quality of life. So this was a really effective intervention that is currently available to be delivered by clinical psychologists who've been trained in it around the country. One of the other things that we learnt from this is that Conquer Fear is not equally effective for everyone, but it is particularly beneficial for people with a high level of fear of cancer recurrence. People with low levels of fear of cancer recurrence benefit equally from relaxation and Conquer Fear, so they don't really need this intensive intervention, which requires them to see a psychologist every week for 5 weeks or possibly longer. But people with high levels of fear of cancer recurrence benefited much more from Conquer Fear. So they appeared to need particularly the metacognitive approach, so challenging and changing those thoughts about thinking. So what we've concluded from that is that a stepped care model, where we might tailor the information and tools more directly to people, is probably appropriate. And I'm just going to skip over that because I don't think that's particularly useful for all of you. So there are some effective treatments for people with fear of cancer recurrence, and the challenge for us is that our sample in the study consisted largely of people with early stage disease, so breast, melanoma and colorectal cancer, and people treated successfully with curative intent, and the intervention was administered after treatment. And increasingly, we know that people are living longer with different stages of disease, and maybe we need to think more carefully about the timing of when we provide some of these interventions to people. So what we're doing now, this one trial has spurned a whole range of different activities that we're trying to develop to make the intervention much more tailored to people at different stages and much more accessible as well. So we're looking at that. We've developed an online self-management intervention that may be helpful for people. So it doesn't require you to go to a clinical psychologist, but it's something that you could do in your own time. Our concerns about that perhaps is that sometimes people do need guidance, and committing to an online intervention can be challenging, and people quite commonly drop out of that. Can we actually deliver stepped care? And we're doing some fantastic work with Lachlan and others at Peter Mac around making sure that we're trying to tailor the delivery of interventions to meet the needs of people with different levels of fear of recurrence. Things like a psychoeducation booklet that people can read in their own time with exercises to do helpful. Can we deliver these things in groups, and is there additional benefit for that? And are some of the nurse-led treatments helpful as well? So they're some of the sorts of things that we're doing at the moment to explore this and to try and make it much more accessible to people and much more tailored to where people particularly are. And I guess one of the areas that we're really interested in is, should we be starting to provide some of these interventions early to help people develop the tools to cope with fears when they arise, rather than waiting for them to develop high levels of fear of recurrence. So that's just a couple of slides about I Conquer Fear, which is currently being trialled at the moment. And so in conclusion, I just said, fear of cancer recurrence is prevalent, but there are things that psychologists and others can do to help you develop the skills and the tools to deal with that. There are effective interventions. We don't really know how fear of cancer recurrence relates to fear of progression, but they seem to be related but not the same. And with cancer increasingly recognised as a chronic illness that people are living with, very long term, we need to understand these things much better. We know that step care to deliver treatments in those people who need them are likely to be much more effective use of resources. And perhaps we could look at different approaches where we might need to tailor some aspects of these interventions for people with particular experiences of particular tumour groups. And I'll just end there with a photo of some of my colleagues who were very heavily involved in the development of this, and particularly for healthcare professionals who are on the line, that a lot of our fear of cancer recurrence resources are available through the POCOG website, so pocog.org.au. And I will stop there and stop sharing, and we can go to questions.
Thanks so much, Harry. There was definitely some overlap between you and Lachlan. I know that you work together, so understandably. Look, it's just wonderful to hear so much activity in this space, which is obviously well overdue and really needed. I think the other thing is that you mentioned the point that this fear to some degree is normal, and that's going to happen. And it's certainly not one size fits all in terms of being able to really tailor this. And again, this whole issue of being able to recognise and be able to intervene early to potentially prevent this from progressing into something that is going to be absolutely limiting your ability to live a normal, productive, happy life. There's been, anyone got any questions? They're coming in now. Just one of the questions that we were going to ask, but I think you've kind of picked this up anyway, was just there is a video, I think, with you and a clinical and health psychologist, which was filmed by Julie McCrossan back in 2020, which really did use an analogy of a tradesperson. The tradies have a variety of tools in their toolbox, I guess, but not one particular tool is going to fix everyone's program, everyone's problem. So I guess that analogy, from what I heard, was totally made sense, because it can be really relevant to people with head and neck cancer dealing with fear of recurrence, that this is not just a one tool issue.
Absolutely. And I think if I can just kind of highlight that, I think one of the challenges is that people, and this is getting back to the question about, who finds referral to a psychologist acceptable. Sometimes people have very fixed or ideas about what psychology sessions involve, and it's not like psychotherapy most of the time, and we're really trying to look at very practical ways to help support people to deal with whatever it is that is a challenge for them. And I really I think that sometimes if we were implementing those tools or teaching people about those tools earlier in their cancer experience or in life in general, then sometimes that's a really effective way to make sure that people don't reach those levels of high levels of fear of cancer recurrence and distress that are associated with other activity, or other life events that are really important. So having those tools and being able to use them when you need to can be a really effective way of coping well.
Yeah, great. A question here. In the case where anxiety persists in the patient, this could eventually lead to a high level of stress, which I think we talked about. Can stress itself affect the efficiency of the immune system in a way that could facilitate a return of the cancer?
So I think this is, Kelly, it's a really common concern in people who've had a cancer experience. And it's kind of interesting because the data doesn't support this from an emotional stressful response. It's much more related to chronic life stresses. So rather than the sorts of anxiety or the distress that you might be experiencing. But having said that, I think it's really important that people do try and manage those things, because they just feel better and can enjoy life a lot more if they're not feeling stressed and anxious about what may or may not be happening to them.
Yeah. I think someone's asking, and I'm sure we'll be able to provide access to the online iConquer Fear. Is there any way that others can access that, or is that very much part of the research? It's
still in the research phase at the moment, but what I will do is just confirm with the lead investigator on that, Ben Smith, and I'll let Nadia know so that perhaps we can, if and when it becomes available, we can certainly link to it through the Head and Neck Cancer Australia website.
Great. There's a question here about finding, because we talked about psychologists, and sometimes that's part of the issue is finding one. So someone's asking here, how do you find an appropriate psychologist who's skilled in FCR and have had issues with, this person has had issues trying to find someone who understands this space? Really good question.
It is a great question. And I'd have to say it is a challenge because there are not a huge number of people who work in psychology around the whole country. I think the best place to start is probably with the Cancer Treatment Centre that you were receiving care from, and see whether or not they have a psycho-oncology service that you could access. The other organisation that's really important and able to provide help in this space is the Cancer Council. So that 11 13 20 number that Kelly mentioned at the beginning, there are people who are skilled counsellors, and they have clinical psychologists working with them pro bono as well. So that's another fantastic resource to access.
Thanks, Harry. And just a comment, and someone has mentioned, Chris has mentioned, that one of the practical reminders of the fear of recurrence is when trying to arrange travel insurance and plan a holiday ahead of time, and that often gets picked up around insurance. So yes, it's always there, isn't it? All right, well, I think we might move on to our panel, but thanks so much, Harry, and thanks to everyone and their questions. I think I've covered just about all of those questions there. So we are next going to, now having heard about some of the theory and some of the research, we are now going to bring in Denise and Ron, and I'll just tell you a little bit about Denise and Ron. Denise Whelan is coming to us from New South Wales, the Central Coast of New South Wales, and she was diagnosed back in May 2017. There she is, there's Denise and Ron. With a rare oral cancer in her upper gums and under the top lip. She's had the cancer removed along with all of the top half of the inside of her mouth and some of the underside of her top lip. But the good news is that Denise has recently celebrated 5 years cancer-free. Yay, go Denise. And she's very grateful for her life and the ability to give back to others by sharing her story. And we're really delighted that she's here to share her story today. And also she's a HANCA ambassador. So welcome, Denise.
Thank you.
And we also have Ron Bongetti, as Nadia mentioned at the beginning. And Ron is in Melbourne. And he was treated at, well, he originally had lymphoma back in the jaw in 2014. And then he was then treated for cancer of the tongue and jawbone. So he was treated at Olivia Newton-John Cancer Research Institute and Epworth Hospital in Melbourne. He's had 60% of his tongue removed and 30% of his jawbone. And Ron is only 18 months post-treatment, but looking pretty damn fantastic there, Ron. So welcome to both of you. We're just going to have a little bit of a chat here, and I will bring in our panel as well. And you are more than welcome to ask them some questions too, if you like. But I guess having heard some of the ideas and the theory and the research and the frameworks that both Harry and Lachlan have talked about today, I'd be just really interested to hear your lived experience. Perhaps if we can just start perhaps with you, Denise. Did you have any experience of fear of recurrence? And if you did, how have you been dealing with it? Is it something that you have now, or is it something that you had in the early days? And how have you been dealing with that?
Thank you. I probably, in some ways, put a bit of head in the sand about thinking about the fear of recurrence, because I had an enormous faith, I guess, in the team that was treating me, the surgical team. And my husband came to each of the appointments, and he often picked up more than I did. So he also had that amazing confidence as well. It didn't mean that I was, oh, well, everything's cool. It just meant I had a bit more of a measured approach to what I should get worried about or what I shouldn't get worried about. But I will add, I got worried about quite a bit. I live 2 hours from where my team is. And so say, for example, after the major surgery, where I did have half my mouth removed, I've got a mouth back now, all good. And I would often have to perhaps get reassurance from my GP. What was this in my mouth? What did he think? And he would give me some reassurance. It was never actually about a recurrence. It was more like, is everything going well? And I needed quite a lot of that. And my surgical team saw me in surgeries. I had 4 of them in the end, and I saw them on a regular basis, 3 to 4 months. But I had other people looking in my mouth, such as my prosthodontist and my dentist. So I guess I had lots of people on my side. It didn't mean I didn't have some moments where, yeah, wow, what's that about? And I had already some good psychological tools in my toolbox, which included having already gone through some psychology, some help, and working out some good things for me to manage myself. And it included things like ACT, which Harry talked about. I'd also started, before my cancer was diagnosed, doing meditation and also art for distraction and getting outside most days. And it's still what I do every day.
So Denise, what I'm hearing from you is that you've used, again, exactly like the analogy of the trading with the tools,
yep.
You've used a variety of different things that you've used for yourself that you're already part of, but you've continued, but also got some more professional help through.
Yes. Absolutely no stigma for me at all. And finding the right person certainly is what Harry talked about. It can be a challenge. But interestingly enough, I was seeing a psychologist before my diagnosis, and she had been managing a project at a university to do with eating in head and neck cancer patients. Can you believe it? And then I was diagnosed. And she said something incredibly helpful to me, who was totally anti the idea that I had to have these tubes in my throat to help me eat and drink and eat and so on. She said, Denise, just see it as healing. Just see it as keeping you going nutritionally for a short amount of time. It's like a medicine. And I must admit, I use that mantra quite a bit. And so I did get some good little snippets there. Yeah.
Great. Thanks for sharing, Denise. Thanks. That's a great tip. Now, Ron, now you're a little different. You had something back in 2014, and I don't know whether back then you had any kind of fear of recurrence back then, because then you've had another bout, a different kind of cancer later on. So what's your experience with fear of recurrence? And again, how have you dealt with that if you've had it, and who have you spoken to?
I think a lot like Denise, in that I had great faith in the team I had around me. So that was a good starting point. I'm a little bit different in that what Lachlan was saying before about not having wasted scans and those sorts of things because they can add trauma. I welcome them. I was one that I like to have a scan. I like to have the blood tests. I wanted to go through all that so that when I went to see my surgeon or oncologist or wherever it was, I knew that at least on that day, I had done everything I could to know if I had cancer or not, and to be cancer-free. So, and there was a question before, I think it was Claire, asked a question about whether if you have it in one tonsil, can you get it in the other tonsil? Well, my first treatment, I had my tonsils out as a biopsy for it all. And my second cancer was on the tongue, probably millimeters away from where the original one was, but they told me it was a completely different cancer. So it was just dumb luck that I got it. It wasn't related to the previous one. So to worry about it probably would have been a waste of time, where my feeling was make sure you go to all your appointments, have all your scans, have all your blood tests, do everything you can, because at the end of the day, I worked on the theory that my job is to help them help me. So if I did my job well, then they can do their job better. And probably the one thing I'd add, which is the biggest fear that I have now going forward after having it twice, and you do wonder whether you're becoming a bit of a breeding ground for cancer, but my worry was that the last time, and I know I've spoken to Nadia about this, was that the original diagnosis of the second one was flawed in that the ear, nose and throat specialist didn't pick it up. It was picked up when I went back to my original radiation oncologist, who put the camera down my throat and found it, because I felt there was something wrong.
So I think, Ron, what you're just saying then is that sense of feeling like you may not you might feel a little bit powerless with the cancer, but the fact is your power, you were empowered to sort of have because you were actually doing, what was the word that you said, doing your bit and having all your scans and having all your treatment, that put you in a sense of, you had a sense of control to some degree where you could. And then you put that trust. It was very much a team approach with your team and yourself working together around this. So did you reach out at all and talk about any of these issues relating to what we're talking about today around fear? Did you do anything that, any little tips that you can offer people around tools that you had that helped you get through this period?
I didn't have any support with a psychologist, only because I didn't seek it. But my mantra was probably to try to be as fit as I can every day. So every morning they gave me some exercises to do in hospital to free myself up. I still do them every day, including my speech therapy exercises. So, and it's just, I don't know, it's probably blind loyalty towards my specialists and that who helped me, but I believe in it, so I still maintain it.
Wonderful, that's fantastic. I know we're getting short on time, but Nadia, you let me know if we feel that we need to wind up, because I know we're hitting the time. But this is to have this great discussion with our with Ron and Denise. Are we able to keep going, or?
Yeah, and I'd love if Hariana and
Yeah.
would like to turn their cameras on. We are scheduled to finish at 1:15, but maybe just if you're still on the line, just give us a couple of more minutes and we'll just have some closing comments from everyone, I think, Kelly.
Yeah, thanks a lot, Nadia. I just thought I'd just check in. I'm just interested, Denise and Ron, or let's go back to Denise first. Anything that Harry and Lachlan were talking about today that really resonated with you? Was there anything there that really resonated with you?
Oh, yes, I wrote notes. Lachlan, your words about words. Oh my goodness. You know, that when the patient left and you went, oh, what did that actually mean? It was in reviewing some of the possible questions I may be asked today that something came back to me. I was attending one of my follow-up surveillances. I didn't even know they were called surveillance till recently. And in just a chat, and it was a throwaway line. It was, oh, you've only had surgery, so if your cancer came back, you can have radio. And that was a throwaway line that has stayed with me, because I must admit I've built up quite a fear of radiation because of what I'd seen happen in others. And so it's not something I'm hanging on to now as a fear or anything like that. But when I first heard it, and then I heard what you said about words, it reminds me that practitioners, perhaps the professionals we see, need to be just a little bit more careful about what they're actually saying, because I took that away with, right. I don't have the fear now as much, but it's still there and I remember it.
Ron, have you got a similar?
Well, if I can comment further on what Denise just said, I had radiation, and I had radiation, quite intense radiation, when I had my first one. And the people there were fantastic in the way that they had advice, and support in how to go. So unfortunately, because I'd had it the first time, I couldn't have it the second time. So it meant because couldn't have it the second time, they had to take a margin, they call it, where they had to remove more of my tongue and more of my jaw to make sure they got it all. So, Denise, if I was going to say anything to you, I'd alleviate any worry about the radiation. They were terrific. It was really good the way they went about it. It was terrific.
I actually have no concerns about the people doing it, believe me. Some of them are most wonderful people. It was the after effects. And I think too, my surgeries were so, in their own way, very brutal and quite traumatic. That first one, when I first heard the words, I'd have to have half my mouth removed and replaced with parts of my leg. That was the most probably shocked I've ever been in my life.
It's amazing, isn't it? I had the same. You know, like they've manufactured a tongue out of my thigh.
Yeah. Well, I've got my leg in my mouth.
Yeah.
That puts a whole new perspective on put your foot in your mouth.
Yeah, yes. But I made the joke first, nobody else could.
Well, I actually tell people if I talk too much, I can get cramped now, so it came down the thigh. But the one thing I'd add to it is that I told my surgeon when I first went to see him that I was going to be the most impatient patient that they've ever had. And when they said that you're part of the team now, Ron, we want you to be informing us of what's going on, that gave me great empowerment. And it meant then that I went back to them with every question I had at any time and suggestions on my treatment and everything. So because I'd had it a previous time, and it gave me some anecdotal support of what I could expect going forward. And my question to everyone would be, with the anecdotal references we're having today, would that be a helpful tool to make sure we add to people's toolboxes? Because I know I've helped 3 people through a similar one that I had with my first treatment, just by being able to tell them what to expect next in their treatment, in their physical well-being and how they're going to be, and ensuring them that they will get through it and go to a next stage. And I think that anecdotal support, I know it helped them And I'm wondering if it would be a handy tool to develop more of that for people if they would do it. Because I know that
Harry, do you want to come in and comment on that? What?
Yeah, I think, you know, having someone with lived experience to connect to can be really an amazingly helpful resource to talk through what to expect and what that actually feels like. And I know I'd have to check. I'm not sure whether this is still currently running, but the Cancer Council again used to run a program called Patient Connect, which was it did exactly that. I'm not sure that how many people that they had with different types of cancer, but there was certainly the opportunity to connect with people from you know, who'd had that experience in the past and could support people through that very effectively. It's a great great.
Is that something, Harry, that that could be included in the self-managed, you know, the online? Is that something that you're incorporating at all, or?
It's not directly. So the online interventions do have, and the booklets as well, do have some reference to the experience of other people through living through fear of cancer recurrence, particularly and some of the things that we're doing to tailor the interventions to different tumor groups or tumor types is making sure that we do have a range of experiences covered, so that we would include the experience of people with head and neck cancer with fear of recurrence, or ovarian cancer, or, you know, whatever it happened to be, which is, I think, probably very important to try and make sure that that's very relevant to the people that are on the receiving end.
Great. Okay, we might just have one more, because I just wanted to pick up again, just to bring Lachlan in here. When you were talking about words, and we were talking about language, Denise, and Lachlan picked that up too, is because there's so much respect and trust for your team. And I think, Lachlan, you raised this too, about sometimes people feel they don't want to raise up, they don't want to ask questions, or they don't want to pick up even this issue of fear of recurrence, because they feel that might, you know, they may not feel that they're respecting their team. How, I guess it's got to be both. How do we, and Denise and Ron, you might pick this up too, but how do we try and empower our people or patients to actually get over this, and to be able to say this without fearing that it's going to reflect badly on the team? I don't know, Denise or Ron, if you've got a comment, and perhaps Lachlan, you might want to come in.
I wouldn't mind saying something. It's about building relationships. And I guess once I was over that first shock of my being told what I had, and then that big operation, I continued to build relationships, and they built with me too. They were checking on me, but I was also sending things like photographs showing my improvement and so on. And Nadia will tell you I'm big on social media. So, you know, my team gets lots of shout outs, and I just am so appreciative and grateful for them. And I figure it's a patient telling the side of the story too. And I have had some contacts made with others, but one of the reasons I'm able to connect with others, I also have a blog. And so from the day I was diagnosed, my blog came into its own, really. So my whole head and neck cancer story is there in the form of blog posts. Thanks.
Fantastic. Anything to add, Ron?
Only that I agree with Denise that the reason I'm even doing today is because of my fondness and support for the people who looked after me. You become very attached to them and very indebted to them. They are lifesavers, literally. So you think, well, if they ask me to do anything going forward, I will do it because it's just, I feel like I owe them and I want to help others. Because doing anything else would be selfish. So I'm quite happy to help out wherever and whenever I can.
That's fantastic.
Can I add, I have my 5-year final visit in October, and I don't know how.
Well done, you.
Anyway, lots of appreciation from my team. Thank you.
Fantastic. That's great. All right. Well, I think Nadia, we probably might need to finish up there, but thank you so much. Sorry, Lachlan, we didn't quite bring you in there, but you had lots of questions at the early stages. We referred to your presentation a number of times, but look, thank you to all of you for being part of this panel. And Denise and Ron, thank you for sharing your story. And I'm sure the health professionals who are on this webinar would be glowing by now to hear your very respect and high regard for them. And as you said, both of you have said it's very much a team and collaborative effort. It's not that someone's doing something to you. It's very much about building relationships and having that trust and that openness to be able to share how you're feeling more broadly, not just on your physical side, but also in terms of your fears around recurrence. So thank you. And thank you to Lachlan and to Haryana for your presentations. Very insightful. I learned a lot myself today. So thank you as well. So just a little clap for you.
And you, just... and you. Congratulations. Well done.
Oh, thank you, Ron. All right. Well, just before we finish, can I just remind everyone that this webinar will be going up onto the HACNA website in the next week or so, or after this, or week or so, I think. And it'll also be on social media. So please check it out. We are also going to be providing a short webinar, a survey link, because, you know, feedback is really important. So at the conclusion of this event, we'll be asking just a few questions for some feedback, because this will inform future webinars, and particularly any topics that are most relevant. And I think this one's been a particularly relevant one to so many different people. Also, just to remind you, there are so many resources on the HANCA website. It's very, very helpful. There's fact sheets, animations, podcasts, webinars, you name it, it is there. So please feel free to reach out onto the website to learn more. And I think that's about it from me. I will hand to Nadia.
Thanks, Kelly. I'll just echo everything that Kelly just said. So very grateful to everyone on our panel and our guest speakers today. As I said at the beginning, we can't deliver these webinars without your input and expertise and personal experience. So thank you very much. I'd like to also just thank again the Western Central Melbourne Integrated Cancer Centre, who've provided funding for us to deliver these webinars. We plan to hold our next one around October, November. And as Kelly said, we really do rely on your feedback as to what topics you want covered. So please fill in that survey. It won't take long. Thank you, everyone. Really appreciate your involvement and have a great day.